In this session, we will take up a topic on chronic obstructive pulmonary diseases, commonly known as COPD. As you know, this is a very common problem for geriatric age group. To my left, Dr. Dwivedi. He is presently professor and head of the department at UCMS in Delhi University, and to the extreme left, Dr. R.S.K. Sinha. He is now senior consultant at Mulchand Hospital in Delhi. They both will be discussing, and I will request Dr. Sinha to start the discussion.
As you rightly said, COPD is a very common geriatric disease. Various synonyms have been used for COPD, like COAD, that means chronic airway disease. Then chronic obstructive pulmonary disease, it is also known as chronic obstructive lung disease sometimes, COLD or COLD, which is classically defined as chronic and slowly progressive respiratory disorders characterized by reduced maximal expiratory flow during forced exhalation. That is the definition ideally given for chronic obstructive lung disease or chronic obstructive pulmonary disease, which I am sure all of you are very well aware of. In such a group of disorder, patients typically have symptoms of both chronic bronchitis and emphysema, but classically sometimes we do have coexistent asthma in this triad of disease. In general, the vast majority of COPD cases are the direct result of tobacco abuse. Other causes are also known, such as a genetic disorder where there is a deficiency of alpha-1 antitrypsin, cystic fibrosis, another genetic disease, common air pollutions. A very polluted town like ours, people do suffer from COPD because of continuous sulfur dioxide exposure. Occupational exposures like firefighters, most common, and disease like bronchiectasis, cystic changes occurring in the lung. So these are the other common causes.
When you said this tobacco abuse,
yeah,
so one has to be very careful that tobacco abuse of any kind, whether bidi smoking or cigarette smoking or hookah smoking or passive smoking.
That is true.
And
so what Dr. Dwivedi is trying to convey is rightly that it's not only COPD, tobacco as such is a very bad agent which can cause to several diseases. COPD is a mixture of 3 separate diseases, and that together forms a complete clinical and pathological picture. These processes are, you know very well, chronic bronchitis, emphysema, and to a very less extent asthma as well. Therefore, we have 2 main types of the disease which are recognized, that is chronic bronchitis and emphysema. Talking about the pathological changes in chronic bronchitis, which plays a major role in the development of COPD. The pathological changes are defined by excessive mucus production with airway obstruction. You should note it that there are 2 components, excessive mucus production plus airway obstructions and notable hyperplasia of mucus producing glands. So these are the main pathological changes leading to chronic bronchitis and subsequently COPD. Damage to the endothelium impairs the mucociliary response that clears bacteria and mucus. Inflammation and secretions provide the obstructive component of the chronic bronchitis, and added on that emphysema is present to a variable degree, is usually different from classical emphysema by virtue of it being a centilobular rather than panlobular. The body responds by decreasing ventilation, hypoventilation, and increasing cardiac output. Eventually, hypercapnia, increased carbon dioxide, and respiratory acidosis develop, leading to pulmonary artery vasoconstriction and cor pulmonale. With the ensuing hypoxemia, polycythemia and increased carbon dioxide retention, these patients have signs of right heart failure and are known as blue bloaters. So these patients apparently have a bloated faces with some tinge of blueness, that is cyanosis. Therefore, a COPD patient predominantly who is having chronic bronchitis is apparently a blue bloater. The second major type is that on which emphysema is predominant. Emphysema, you all know, is defined as destruction of airways distal to the terminal bronchiole, more of septa and alveoli. Physiology of emphysema involves gradual destruction of alveolar septi and of the pulmonary capillary bed, leading to decreased ability to oxygenate blood. Simple. The body compensates with lowered cardiac output and hyperventilation, just opposite of what happens in chronic bronchitis, where there is high cardiac output and hyperventilation. In emphysema, it is lowered cardiac output and hyperventilation. Eventually, these patients develop muscle wasting, they get emaciated and are identified as pink puffers. So, they do not have very obvious cyanosis, rather they have more of polycythemia and pinkish color, and they have their lips like puffing all the time.
Okay, Dr. Sinha, as you rightly pointed out that mainly two types, emphysema and bronchitis group, and you also identified them as blue blotters and pink puffers. Now, while taking history as a student, what are the important points they need to highlight so that they can take out all the information from the patients and can also present it?
Right. So, while we take a history, patients with COPD presents with a combination of signs and symptoms of chronic bronchitis, emphysema and to some extent at sometimes asthma as well. Symptoms include worsening dyspnea, progressive exercise intolerance and alteration in mental status in extreme cases. But in the chronic bronchitis group, classical symptoms include productive cough with progression over time to intermittent dyspnea, frequent and recurrent pulmonary infections, progressive cardiac respiratory failure over time with edema and weight gain. So, these are the classical signs. Whereas in emphysema, the history is somewhat different and may include the following set of classical symptoms, that is a long history of progressive dyspnea with late onset of non-productive cough. So, in chronic bronchitis it is cough which is predominant to begin with, here it is dyspnea to predominantly to begin with. Occasional mucopurulent relapses means secondary infections often causing purulent expectoration. Eventually these patients are cachextic and develop respiratory failure. So, opposite of what happens in chronic bronchitis. Coming to physical examination, the patients of chronic bronchitis who are mainly blue bloaters, they may be obese, they may be having frequent cough and expectoration. Use of accessory muscles of respiration is common. Coarse rhonchi and wheezing may be heard on auscultations. Patients may have signs of right heart failure, that is development of cor pulmonale, such as edema and cyanosis. Pink puffer, that is predominantly emphysema patients, may be very thin with a barrel chest. They typically have little or no cough or expectoration. Breathing may be assisted by pursed lips and use of accessory respiratory muscles. They may adopt the tripod sitting position, as if bending forward, supporting himself on hand. The chest may be hyper resonant and wheezing may be heard. Heart sounds are very, very distantly heard. So,
okay.
These are the features which we find in two different predominant situations of chronic bronchitis.
Dr. Dwivedi, will you like to highlight some of the important points so that the students will know that okay, these are the issues where they have to concentrate more?
I think whenever we deal with cases of this COPD, chronic obstructive pulmonary airway disease, it's very important that salient points emphasis must be done. What is the type of cough? What is the type of cough? Whether the cough is more dominant or dyspnea is more dominant, because that decides the issue whether the patient has chronic bronchitis or the patient has basically emphysema. That is one part. And along with cough, whether the patient has cyanosis or fever. This again denotes that whether patient has associated infection. Second point is because invariably these patients are a smoker. So along with the smoking, there are other diseases are also which are silently associated with this, like presence of hypertension. So take the blood pressure, at least look at the blood pressure. These patients may also have associated asymptomatic coronary artery disease. It's nice to keep your eye whether this patient also has associated coronary artery disease, because these are elderly people. Then again, because of the chronic obstructive pulmonary airway disease, these patients may be having features of some hernia, or these patients might be having associated benign prostatic hypertrophy. So ask those, a system review should also be done, and we should concentrate, not lose the track or sight of these associated disorders.
These are the things we have to keep in mind.
Yes, Dr. Dwivedi has once again emphasized in examining the patient in totality. That is the established norm which should never be forgot. I am sure you will all agree that besides respiratory system examination, emphasis on other parts should not be neglected, and it's very good that Dr. Dwivedi pointed out the other
so I think the issues will be more highlighted if we discuss the differential diagnosis, the other components.
So when we get such a patient, we should not only be focused on COPD as the only cause, we need to differentiate it from other possible causes.
Right.
So in differential diagnosis, we must exclude the diagnosis of acute respiratory distress syndrome. I am sure you know about these things. We need not go into much detail, or maybe we discuss it at some other occasion. CHF, congestive heart failure, left ventricular failure, myocardial infarction, yes, acute presentation often mimics an acute exacerbation of COPD. Panic disorder, totally a psychosomatic disorder. Pleural effusion, yes, massive effusion suddenly can mimic such a presentation. Pneumothorax, Dr. Dharman did focus mainly in the morning. Pneumonias, he did mention about that as well. Pulmonary embolism, one must not forget in such a situation as mimicking a COPD acute exacerbation presentation. So these are some of the important diagnoses which need to be kept in mind while managing such a patient of COPD. So, well, when we come across such a patient, we need to go ahead and establish our diagnosis, and for which we need to take a total comprehensive history, a complete clinical examination, and support is required from laboratories. So laboratory studies in such a patient can include ABG, arterial blood gas analysis, which provides the best clues as to acuteness and severity of the disease. In general, renal compensation occurs even in chronic COD retainers, that is bronchitic type of COPD. Thus, pH in ABG is usually in the normal range. So, just looking at ABG and pH being normal, don't declare the patient is quite safe. There could be an ongoing renal compensation which has maintained a pH to the normal side. Generally consider any pH below 7.3 as a sign of acute respiratory distress. That is very, very important. Then in serum chemistry, these patients tend to retain sodium, so hypernatremia is possible. Diuretics, beta adrenergic agonists, theophylline, all of which is commonly used in the management of COPD with cough pulmonale, act to lower potassium levels, produces hypokalemia. Thus, serum potassium should be monitored carefully in such a situation. Beta adrenergic agonists also increase renal excretion of serum calcium and magnesium, which may be important in the presence of hypokalemia, which can complicate the hypokalemic effect on the body. And then polycythemia could be another observation from the laboratory investigation when we do complete blood counts.
I will request Dr. Dwivedi, can you tell, because he had narrated a list of the differential diagnosis, there are other associated causes which should be also looked into, even you have mentioned few, and maybe those will be linked to some of the investigations. Can you just highlight some of them?
We did touch this issue in our previous discussion, that the associated comorbidities along with chronic obstructive pulmonary airway disease in elderly patients are hypertension, coronary artery disease, cerebrovascular disease, benign prostatic hypertrophy, or hernia, or bronchogenic malignancy, because again the link is same, the smoking. That is the link that has got to be seen. And based on this, whenever there is associated comorbidities, you have to plan your list of investigation accordingly. I think it will be nice to add which I am sure Dr. Sinha is coming later on about other test imaging, chest X-ray, ECG and other things. But most important, what Dr. Sinha has very rightly said, we must concentrate on the pH, because pH is a very good monitor, that prognostic parameter by which you can decide whether your patient needs acute ventilatory support or not. And then serum potassium level, this is also very important, because some of us we tend to give diuretics, we tend to give digoxin, which in the case of hypopotassiemia, with the serum potassium is low, if you have not measured it, you are landing into trouble. So that is very important to my mind, and which Dr. Sinha obviously has dealt.
Right, Dr. Dwivedi has further emphasized on those points, and I am sure students would agree that these are very important observations which we should keep in mind.
That's right.
Then coming to other supportive investigations like imaging studies, which obviously most freely available is a chest X-ray at every center, every PHC as well sometimes. In chest X-ray, in cases of chronic bronchitis, we find very few changes, and that is in form of increased bronchovascular markings and cardiomegaly if the cor pulmonale is setting in. In cases of emphysema, there is a small elongated heart, evidence of hyperinflation, that means increased translucency, flat hemidiaphragms and possible bullous changes. So these are the changes which should be noted in chest X-ray. Then pulse oximetry does not offer as much information as ABG. There is no substitute for ABG. This is just a bedside quick monitoring tool. When combined with clinical observation, this test can be a powerful tool for instant feedback on the patient's status. As rightly said, less than 90% saturation, oxygen saturation, one should become alert in providing the patient best ventilatory support or improving the oxygenation. Electrocardiogram, the presence of it can depict the presence of underlying cardiac diseases, which is very highly likely. Dr. Dwivedi has been again and again emphasizing on this component, that just don't only focus on lung disease. A chronic smoker, because of so many reasons including chronic hypoxia, is a much more potential patient to develop coronary artery disease as well. So don't forget that. Establish that hypoxia is not resulting in ischemia, that is important. Establish that the underlying cause of respiratory difficulty is not cardiac in nature. All this can be simply established by doing a bedside electrocardiogram, ECG. Pulmonary function test, we have discussed that. It depicts that decreased forced expiratory volume in 1 second, that is what we call it as FV1, with concomitant reduction in FV1 and FVC, forced vital capacity ratio, is the hallmark of COPD. Poor or absent reversibility with bronchodilators differentiate it from bronchial asthma. FVC normal or reduced, FVC as such as a single parameter may be normal, but when we combine it with FV1 and take a ratio, that will be decreased. So normal or increased total lung capacity, so don't depend on TLC mainly, it can be normal or even increased in such a situation. Increased residual lung volume, that is very, very important, that there is a incomplete exhalation and there is increased residual volume. Normal or reduced diffusing capacity, if we can do that DLCO2 test, there will be a decreased capacity of diffusion demonstrable in such a patient. So with these investigations, we can somehow diagnose, suspect and diagnose the patient, and at least have an idea of the severity and the chronicity of the disease in
So probably in the inhibition, you pointed out towards and that total lung capacity increases, but simultaneously residual volume that also increases.
Of course, when we have diagnosed such a patient, we have to treat. The treatment of COPD mainstay for acute exacerbation are oxygen, bronchodilators, and definitive airway management. So these are the three things we have to offer to a patient in emergency setting as well as subsequently. So in emergency department, when a patient in acute exacerbation lands up, in addition to oxygen, the emergency department care may comprise bronchodilators, antibiotics, CPAP or biphasic positive airway pressure, continuous positive airway pressure or biphasic positive airway pressure by ventilatory supports, and definitive airway management via intubation. These are the main treatment modalities which should be available in emergency while managing COPD. All of these should be considered in the context of the individual patient's condition. What should be used, which is dependent on the severity of the disease and the individual patient's condition. Oxygen, adequate oxygen should be given to relieve hypoxia. The foremost important treatment which is never be compromised on, The need for intubation can be established quickly at the bedside by simply asking the patient to hold the nebulizer in his or her hand. If the patient becomes so sleepy that the nebulizer starts to fall away, the patient should be intubated regardless of what is his or her PCO2 level. So this is a simple bedside method which tells us when to become little invasive and provide intubation. Occasionally, large increases in CO2 level can lead to deterioration of mental status, causing stupor and consciousness obtundation basically. In such cases, decreasing oxygen delivery is the wrong action. Never cut down on oxygen and don't think that oxygen toxicity is occurred. The carbon dioxide narcosis inhibits respiratory drive to the point that decreasing oxygen delivery leads only to worsening of hypoxia. So don't cut down on oxygen delivery, that is important. The correct action is immediate intubation and oxygenation. Bronchodilators, these agents act to decrease muscle tone in both small and large airways in the lungs, thus increasing ventilation. Categories of bronchodilators include subcutaneous medications, beta adrenergic agonists, methylxanthines and anticholinergics. Note that only 10 to 15% of all patients with COPD have a true reversibility, that is bronchospastic component of bronchospasm. However, because predicting response is impossible on presentation, nobody can predict what will be the response. All patients should be treated with aggressive bronchodilator therapy. There is no controversy in it. In the pre-hospital setting, administer only beta agonist nebulizer therapy, which should be given as needed. Although only a small subset of patients respond to beta agonists, a continuous nebulization as is seen in current asthma treatment may be beneficial. So don't hesitate in providing a continuous beta agonist nebulization. Anticholinergics seem to have an important role in the acute treatment of COPD exacerbation. Theophylline acts to increase collateral ventilation, respiratory muscle function improves, mucociliary clearance is improved by theophylline, and central respiratory drive also improves by theophylline. It also acts partly by causing relaxation of smooth muscles in bronchi. However, clinical efficacy is controversial, especially in acute setting. It is advocated only if patient was taking medicine already and had subtherapeutic level. Do not give IV form, especially of aminophylline, because it can precipitate arrhythmias, especially in patients such as these ones who are already in an excess catecholamine state.
I think Dr. Samaya, what you said very rightly in the beginning, that first thing is the oxygen. You must ensure that the patient gets the oxygen. That is one, by whatever form you want to do. And second is nebulization. Immediate bronchodilator should be given. And as you were emphasizing in the last slide, that perhaps use of theophylline should be with needs a great caution. Usually these are the patients who are elderly patients. They might be, again I am coming back to that point again and again, they might be having a compromised coronaries or coexisting asymptomatic type of coronary artery disease. So in these cases giving theophylline is sometimes full with danger, and its relation with a tendency to produce hypopotassiemia. Then again it puts the patient into the danger. IV never. I will go to that extent. IV never. You can only use if you have a suspicion that he was perhaps using suboptimal level. Otherwise the sheet anchor of the therapy again remains the oxygen and the bronchodilator,
like
that
beta
is by
agonist.
beta agonist.
And parasympathetic.
Yeah.
Ipratropium or tiotropium bromide, which are anticholinergic medications, they appear to inhibit vagally mediated reflexes by antagonizing action of acetylcholine, specifically with muscarinic receptor on bronchial smooth muscle. Vagal tone can be increased by as much as 50% in patients with COPD. So this can have a profound effect on the outcome of the disease. Therefore, these anticholinergic medications have a tremendous role in the management of COPD. We should not forget about that. So we can select any of these two available brands, ipratropium or tiotropium, which are available as inhaler form very freely. Those can and should be mixed with first beta agonist nebulizer, because it can take up to 20 minutes to begin having effect. So don't, you see, these anticholinergics are not the very quick acting bronchodilators. So obviously we need to give a very quick acting bronchodilator to begin with, and therefore this anticholinergic medication should be combined with shorter acting beta agonists. Corticosteroids, well, these agents have been shown to be effective in accelerating recovery from acute COPD exacerbations. Controversies is carrying on. Although they may not make a clinical difference in emergency department, they may have some effect by 6 to 8 hours into therapy. Therefore, early dosing is critical. Sometimes we may wish to give steroids early in the management, hoping that after 6 to 8 hours the effect will come. Some newer studies are suggesting that inhaled corticosteroids, for example nebulized budesonide, may be equally effective as intravenous or peroral steroids. So the nebulized form is as good as giving intravenous steroids, in the mild to moderate exacerbation cases. However, further studies are continuing and we need to support it. Random use of antibiotics is still controversial, whether we should use it or not. There is no consensus on it, but in a patient who is acutely ill, has come with some evidence of infection inside, fever, altered color of expectoration from grayish to becoming yellowish, probably we may consider using antibiotics in such a case.
Dr. Salah, there have been newer beta agonists, some recent advances, perhaps the students would like to.
Well, yes, beta agonists, we have very shorter acting and longer acting ones. You all are aware of salbutamol, vitaline as the shorter acting beta agonist. The total effect of such a shorter acting beta agonist lasts for about 6 to 8 hours. Action is very fast. Then there are other longer acting ones like salmeterol, which takes longer time to act on, but the action lasts for about more than 12 hours or so. Then we have pharmacological now in market as the longer acting beta agonist with a faster acting component in it. So this formoterol probably becomes a rescue beta agonist as well as a maintenance beta agonist, whereas salmeterol is only for the maintenance beta agonist, maintenance therapy. Salbutamol or terbutaline becomes the rescue beta agonist. So when we wish to pick up one of those beta agonists, we must put into a clinical situation. If we want to manage the acute exacerbation, rescue the patient, then probably one of the shortest acting, which are quickest action, having quickest action. When we want to give a both combination of quick action and a sustained action, that then probably formoterol is the preferred agent. When we only want to have a maintenance therapy for a longer action, then salmeterol is in it. Here the point of interest is, again, it should not be given as a monotherapy, especially the longer acting ones, because it suppresses the basically inflammatory response. Therefore, it has to be combined with maybe steroid, so that the inflammation which is ongoing can also be managed. So monotherapy should not be preferred, it should always be given as a combined therapy.
Should be avoided. What about the role of domiciliary oxygen in such cases? Because
yes,
sometimes these patients do come.
Yes.
We have to emphasize upon
I think one of my subsequent slide will mention about that too. But domiciliary oxygen is the mainstay of treatment in such patients of COPD, especially who have gone into a stage of pulmonary basically. And there is, I have heard that there is not much of emphasis on such a therapy in practice, but it is seen and observed in several studies that longer the oxygen therapy given at home, as that definitely improves the patient's general condition, quality of our life, as well as longevity is definitely
overall prognosis.
Overall prognosis.
That's right.
A minimum oxygen of about 15 hours is recommended at a rate of say 2 to 4 liters per minute in a day. Gives a definitely improved quality of life to such a patient, and longevity improves. So one should consider. And you know, there are several ways of providing oxygen at home, through cylinder, through oxygen concentrations, as the patient's condition
depends upon his affordability and
one should
logistic resources also.
That's important. But oxygen therapy, domiciliary, continuous, low dose is a very important subsequent therapy to improve the patient.
During the intervention period.
That's right.
Yeah.
That's right. Okay, so once we have managed the patient in emergency department, we would like to continue the further treatment in the hospital, and in extreme cases CPAP or BiPAP may be attempted prior to intubation. You know, intubation obviously becomes an invasive way of treatment. So a CPAP or BiPAP, if ventilator is available, can be tried. This can be started in the emergency department itself and continued for several hours in the hospital, several hours and several days as well. Usual recommended settings are on, I am going into a little detail of this, are an inspiratory positive airway pressure, IPAP, of 10 centimeter of water, and an expiratory positive airway pressure of 2 centimeter of water. That is the usual recommendation to set that BiPAP treatment, in fact, with further adjustment based on the individual requirement, how the patient improves. This treatment is not a substitute, mind it, is not a substitute for intubation. Rather, it is a means of trying to avoid intubation. So as soon as we find the patient is not improving with this, we should not delay intubation, definitely no. For patients who are sent home, in fact, that was mainly in the hospital, and as Dr. Dwivedi has emphasized that there is no substitute for oxygen therapy. There are ways to give, from nasal oxygen therapy through mask, through ventilators, BiPAP, CPAP, and ultimately by intubation. So that management continues for some time in the hospital, and once the patient improves and is fit enough to be sent home, the treatment continues as in the outpatient as well. And for these patients who are sent home, nearly all of them should receive a short steroid burst and an increase in the frequency of inhaler therapy, whatever he has been on. Close follow-up should be arranged with the patient's regular health care provider. Other therapies should be considered on a case-by-case basis. That's important. That obviously requires a closer observation by the treating general practitioner, physician, whosoever is managing the patient. Patients with severe or unstable disease should be seen much more frequently and at least once in a month.
That's right.
should not be ignored. So, how can we prevent or deter such a thing? For the vast majority of patients, cessation of smoking is the only true means of prevention. Remember that cessation of smoking is never late. The day it is stopped, the prognosis improves. It has got some amount of obviously reversibility also. It has been seen stopping smoking sometimes reverses the progression of the disease. It reverses the obstruction basically. So, never consider cessation of smoking a delayed process or impossible. And it is not an impossible task. People feel that once patient is addicted or dependent on has become too dependent on smoking, it is difficult to leave or abandon smoking, abstinence from smoking. It is not true. It is always possible. Only thing is we must be able to convince the patient. You create a good counseling environment and you will be a great success. Well, as any disease, any other disease, COPD is also not free of complications. There are complications that must be anticipated in a COPD patients, and these could include incidence of pneumothorax, which can be due to bleb formation, which is relatively high. Consider pneumothorax in all patients of COPD who have increased shortness of breath. Suddenly patient worsening, his dyspnea worsening, consider pneumothorax. In patients who require long-term steroid therapy, the possibility of adrenal crisis is very real. At a minimum, patients with steroid dependent COPD should receive stress dosing. During stress, increase the dose of steroid, that is important. Infection is a very common complication associated with COPD. Cor pulmonale, well, long standing COPD is always a potential cause of cor pulmonale. We will discuss in next talk by Dr. Dwivedi. Secondary polycythemia is very well known with its sequelae and complication in itself. Bullous lung disease, acute or chronic respiratory failure, pulmonary hypertension, and malnutrition is a very important complication. So, these are not to be ignored. Prognosis, patients, prognostic factors are mainly patient's age and post bronchodilator FEV1. Young age and FEV1 greater than 50% of predicted are associated with good prognosis. As the age progresses or the FEV1 falls, the prognosis worsens. Supplemental oxygen, when indicated, has been shown to increase survival rates, which we have just been discussing. Smoking cessation improves prognosis, very important. Cor pulmonale development of hypercapnia, tachycardia and malnutrition, all those contribute towards poor outcome. How to educate patient for further improvement in this condition? The best education comes in two forms. Educate patients to the dangers of smoking and the improvement in quality of life attainable with smoking cessation. Instruct patients with COPD to present early during exacerbation and not to wait until they are in distress.
Thank you, Dr. Sinha, for nicely discussing the cor pulmonale, the COPD in details. Maybe we will take up some of the issues later on.
Thank you.